You're now live on YouTube, Chair. I'll leave you to it.
Okay, thank you, Gordon. Welcome everybody then to the April meeting of Rotherham CCG. We have apologies from Councillor Roach, who is he's not having a Zoom malfunction, he's having a complete electric malfunction at his house at the moment. So he has every sympathy on what turns out to be a very cold April day today, when he doesn't have any power. However, we are quorate. Are there any declarations of interest above and beyond what's already recorded? Okay. Draft minutes of last month's meeting then, for accuracy and anything that isn't on the action log. Page 1. Two, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, and 13. Okay, thank you, Lindsay. We'll take those as an accurate record. There is an action log, but I temporarily mislaid it. Anything on the action log? Sorry, I can't see it. I just have to find my copy.
No, Chair, there weren't any outstanding items noted.
Okay, that's fine. Okay, in which case, oh, sorry. Trying to find that has put me off. Chief Officer report then, Chris.
Okay, good afternoon, everybody. A few things to update on today, so I'll just go through in order. So first is just to remind the governing body we're in a pre-election period, so we're in a PERDA period. We do have all-out elections this time in Rotherham on May the 6th. So just a reminder, just in here is there's full guidance is attached, but really no new decisions or announcements on policy or strategy are permitted. No decision on large or contentious procurement contracts, and no participation by NHS representatives in debates or events that may be, sorry, there's a little typo there, may be politically controversial. So just in terms of our agenda, we've just checked that just to make sure we're compliant with the requirements of PERDA. And Chair, we might just have to be mindful if anything comes up during the meeting that would breach those conditions. But otherwise, we shall be back to normal when we meet in June. It will affect our May meeting as well, won't it? So just to note. The second thing is, since we last met, the operating guidance for 21-22 has been published by NHS England. Unusually, this is for a 6-month period to the end of December. Never really happened before, but we're expecting then to have the second half of the year, there'll be additional guidance published, and our planning will, I guess, will have to be refreshed. So we're now in the process of coming up with plans for the next 6 months, which will have very tight deadlines on. And we'll work through with partners to make sure and work with ICS colleagues to do a place-based plan and a ICS-based plan. So I expect us to bring to our next meeting our submission or our initial submission for governing body members to see where we're at and be assured about our planning processes. The next thing is just to report that on the 25th of March, we've been moved from a level 4 to a level 3 incident level on a national level. That means we'll start to move away from national command and control, and we'll now see a transition to a more local coordination of regional command and organisational commands. In terms of reporting requirements, the COVID-19 and EU exit requirements will start to be reduced and relaxed to be more appropriate to a level 3 position, and the national incident coordination will be at place level. So in terms of us moving, we're now moving, it feels now, to the next phase of responding to both the EU exit and the pandemic. So just moving on, we had the national staff surveys published in the last month. Rotherham CCG, when we benchmark ourselves against other organisations, performed very well in the national staff survey. I picked out an article in the Health Service Journal just for governing body members to get an idea for where we sit nationally. And amongst the CCGs completing the staff survey, we ranked the second highest place where people would recommend as a place to work. So I think in terms of a management team, we're obviously very pleased to get that result, and hopefully it gives governing body members assurance that the environment we're creating as an organisation leads to hopefully a happy and healthy workforce. So just thought I'd put that in as a positive note as we go through. I'll just stop there, Richard, and see if anybody's got any questions.
Okay, thank you, Chris. Any questions for Chris on that paper? No.
Okie doke. Shall I move on then? Because I'm next on the agenda, Chair, with the integrating care next steps.
Keep talking.
So yeah, I've put this on as a standing item. So obviously we had the draft white paper published. We're expecting a second reading in May or June, and that date's still to be confirmed. What we haven't seen is any further guidance come out since that. I think we are expecting a few documents to come out over the next few weeks, you know, as guidance to the future. But in terms of legislation, it's looking like it's going to be probably June time before we get any further legislation. So as things stand, it's as we were. We've got the draft white paper still to go through Parliament, and we'll just keep on trying to, we're trying to respond as a place. So we're doing things like working with Rotherham partners to try and work with the principles of that white paper to make sure that Rotherham as a place is in a position to respond to whatever comes out. So no tangible updates, but we're just a direction of travel update.
Okay, thank you, Chris. It's you again. That was you again, Chris.
Yeah, so this is a report that comes to the Health Executive Group, a part of the ICS, and I put it on our agendas just to make sure that everyone's fully cited on everything that's happening at a South Yorkshire level. I don't intend to go through the report line by line, but I'm happy to take any questions if anyone has any questions on the report.
Any questions on this report for Chris? Okay. Right, in which case we shall move back onto the performance reports. So Wendy, finance and contracting.
Thanks, Chair. Ooh, apologies. Apologies, I just need to get my report up. There we go. Sorry for that. Well, I'll continue with the positive news theme. As we move into month 11, so the report today is at month 11. I've got little to update you on in terms of that we are on track to achieve the surplus that we last declared, so the £1 million. So really, I've just got two things to give you assurance, as you can see in sections 2 and 3, that cash and payments continue to be really well managed and are in line with achieving the demands there that are on us nationally in those areas. And then literally to draw your attention to the £1 million in the operating cost statement at section 5, where we anticipate sticking at that forecast now. The only risk to that, and it's highlighted in the section 12 in the risk section, would be if we get any further allocation adjustments, and they would need to be significant at this stage. They would be likely to come from NHS England in relation to things that happened in the month 1 to 6 period, but we're not aware of anything at this point in time. So I'm just asking you to note that position and the detailed narrative within the report, and I'll pause there, but I'm happy to take any questions.
John has a question.
Wendy, it was just really around declaring a surplus, and I know that, you know, we believe that's the right professional financial position to report, but that's a position that's better than plan. I'm just really checking that there's no pressure on us to change that position, and that reporting a surplus is acceptable?
It is, John. Yes, it's noted, and we are in the pack as well. Other CCGs and indeed trusts are in the same position. So yes, it's acceptable this year.
Okay, any other questions on this paper for Wendy? Okay. I can't tell if that's Ryan raising his hand or adjusting the light. Is that you raising a hand, Ryan, or? Okay. Okay. Moving on then, Wendy, the mental health investment standards.
Thanks, Chair. So with this one, just to say to governing body that whilst we're about to move into 21-22, this paper is in fact in relation to the mental health investment standard for 1920, just to avoid any confusion. So there is a national planning requirement, as you know, in relation to the mental health investment standard, that CCGs increase our year-on-year investment. And for the year in question, that was by an overall programme growth plus a 0.7% increase. So in total, we were required to increase spend by 6.49% over and above 18-19 outturn. Separate to that investment requirement, CCGs are then required to engage an appropriately qualified independent person or reporting accountant, in our case KPMG, to provide reasonable assurance that the standard has been met. So as I say, we employ KPMG in doing that work. In terms of performing that work, it's a very detailed piece of work where we provide details to KPMG of all the mental health expenditure, and they assure themselves, check it against the national requirements and assure themselves that we have counted the correct things against the standard and therefore that we have achieved it. So their assurance work has concluded that the CCG has complied with the planning requirement, and they would intend to issue an opinion to that effect. But before they can do that and finalise their report, they require Chris to sign 2 documents, and that requires you governing body supporting him or allowing him to do so. So the documents are attached there, and you know, I am able to give you assurance that we have, to the best of our knowledge, provided everything that we know. Not to the best of our knowledge, we have provided all information to KPMG that we had at our disposal and that they asked for in relation to them being able to come to this assurance opinion. So as CFO, I can give you that assurance, which is similar to the final accounts. You need that assurance from me that we've done everything that we think we should have, and that we've provided everything to the KPMG to allow them to come to their assessment of assurance. So it's here today to ask governing body to give your support to allow Chris to sign these documents. I'll pause there, Chair.
Okay, thank you, Wendy. So this is a pre-pandemic document, isn't it? Pre-pandemic.
Yeah, it is. Yeah, it takes a long time to get the mental health investment standard through process.
So just to confirm, John, that KPMG did come to Aqua to confirm this.
Well, no, but the timescales are such that there isn't an audit committee meeting until next week when we normally look at that, and this document needs to be signed off, as I understand it, from a timescale point of view before then. So that's why it's coming to governing body first, because it's not been practical to take it to Aqua. But you know, I agree with Wendy really that we're getting the professional assurance from Wendy in terms of the spend, we know that has been appropriate, and we've we've got the independent assurance from KPMG, which I've seen through Mark. And so, I support what Wendy's saying and recommend that the governing body allow Chris to sign this off.
Okay, so for that line, analysis of key issues and risks, it says that KPMG has already confirmed at the last AQUA their intention. So has that happened or not?
Yes, it's been it's been discussed. The fact of that KPMG were intending to do this has been discussed at a prior AQUA. But yeah.
That's why I just want John.
Yeah, it has. Yeah.
I was thinking you meant the outcome, but
yeah.
It was part of the external audit plan, so we knew this work was being done, and Matt Jones in Wendy's department has shared the process and the work with me, but it's not formally been to AQUA yet.
Fine, that's why I just want to confirm that bit of the process. So otherwise, any other questions? Are we therefore happy for Chris to sign his life away? Okay, fine. I can see people that saying yes. So Chris, we're happy for you to sign that document.
Yeah, that's fine. And just to say, obviously, I'm very comfortable with this. And when we speak to our mental health providers, they're very comfortable with our approach as well.
Good. Okay. Okay, moving on then. Ian, delivery dashboard.
Yeah, thank you, Chair. So just for members, this is just enclosure 10C on the delivery dashboard, just noting that and expecting colleagues to have a quick look over it. So by exception then, this is our reporting period that covers January and February, and I don't think colleagues need reminding of the challenges that the system's been under during that period of managing the COVID pandemic. And again, just for context, during this period, the hospital has had well over 100 COVID inpatients at any one time throughout January and February. That position has now significantly improved. Latest position around 20 inpatient COVID patients. So you can see how that's changed, and you'll see that through my narrative as we talk through this report, Chair. The plans now link back to Chris's point in his Chief Operating Officer report around recovery, where there's a real focus on recovery now. But in terms of the performance element, it continues on the theme of significant challenge. And even on page 1 there, you can see, page 2 of the PDF, page 1 being the covering paper, being the kind of key point on the national versus the CCG stroke trust position. And you can see at a national level, the significant challenge under core performance metrics, and then Rotherham's not different to that view. So I think what I would just flag is that on the A&E paper, on the A&E part of the paper, where you can start and see attendances, for the first time in the last few weeks, we've started to see attendances in A&E for the first time comparative to the previous year starting to increase. We are now starting to see increase in footfall back through our A&E department, not to the levels that we'd seen probably 18 months ago, but it's definitely increasing towards the 240 to 250 a day, which again, from the levels of 190 a day, is quite a significant increase. So we're just trying to manage that with our partners. Just a few other things to flag. Our IAP performance is maintaining itself within there, which is positive. We continue to do work around our patients that require cognitive behavioural therapy, and we'll continue that dialogue as part of the IAP pathway. But comparatively, we are in the pack with regards to our IAP position. Cancer weights as well as elective care is one area that we really need to focus back in on. Not that we've not been focused on it, but just to try to improve our performance. It's one area of challenge. You'll see the cancer performance in the paper. And a lot of our recovery work is around South Yorkshire level, around trying to improve our cancer performance position going forward. From an elective perspective, we do, again, challenged on our elective position. Our performance at 73% is not where we want it to be comparative to where we've been in previous years. We do have significant high numbers of 52-week waiters, which are illustrated in the point there. And again, that will be a key focus of our recovery discussions with our local trust and actually across all of South Yorkshire, as we try to manage the elective part of recovery over the kind of coming weeks and months. But this will be a longer period of time to deliver on all this aspect. Linked to that is our diagnostic position, so the 6-week wait target. Again, we prided ourselves on delivering this target, being best in the country at that pre-COVID. We now find ourselves in, unlike other areas, in a real challenge position to get back on track with diagnostic work, and we'll be bringing through plans around our approach to improve the diagnostic capacity in the coming weeks and months. So I hope that just covers off the summary there, Chair. We'll obviously open it up for feedback and comment now. Thank you.
Thank you, Ian. Any questions? I mean, we're obviously supporting the trust and getting their wait times. How's our team engaging with them? Is it feel that the acute trust has a good plan for getting everything back on track?
Yeah, so the planning guidance that we'll discuss in a little bit more detail in the confidential governing body, but the public element of that is there is some quite challenging targets in terms of trying to recover and get plans in place. On the elective side of things, the trust are, as they have been doing throughout the pandemic, prioritising patients on a priority scale of 1 to 4, priority 1s and 2s being needed to be done in a matter of weeks, making contact with all patients accordingly. I think one of the key things out of particularly on the elective recovery and with cancer, which is reflected in the national guidance, Chair, is the need to probably manage it more at scale, so at like a South Yorkshire and Bassetlaw level, in order to ensure that we get equity and we don't add additional harm to patients or create additional inequalities as different parts of the system recover at a different pace. So that is an expectation I'd ask, and we'll describe back to the governing body how the system's going to do that at a future point. Thank you.
Thank you. Any other questions for Ian? Okay, shall we move on then to Sue and safety and quality report?
Thank you, Chair. So starting with enclosure 11 and the safety and quality report. So starting at the beginning there, I'll give an overview of some of the main points and take questions if that's okay. The infection prevention and control work continues to review and investigate rates and individual cases of C. diff and E. coli across the system, with the CCG working very closely with TRFT and other partners there, and the information is in the first few pages there. CCG are also active members of the Health Protection Board and the Local Outbreak Engagement Board, where oversight of COVID is provided. Rotherham are seeing higher levels of positive COVID tests recently, and Public Health are reviewing this, including the percentage of asymptomatic positive cases against those with symptoms. The numbers of COVID positive inpatients at TRFT, as Ian's already mentioned, are falling. We're also seeing the numbers of those who are more seriously ill with COVID and requiring intensive care and oxygen therapy falling as well. The vaccination programme progresses across Rotherham with, I think we're around about over 135,000 people having now been vaccinated across the top 9 priority groups. And this represents over half the adult population of Rotherham. The main focus this week is on ensuring that those that have received the first dose now receive their second dose within the 12-week timescale. The primary care networks, the Federation and the CCG are working very closely together to affect this. A lot of work going on behind the scenes, as well as the delivery at the sharp end of that, and supported by volunteers as well, which I'll come on to in the next report. Page 4 outlines the work around mortality rates, and though remaining an outlier, the Trust TRFT have seen a fall in mortality for the last 3 months recorded in this report. The data relates to July, August and September last year, which is suggestive of a move in the right direction, though it's not yet clear what the effect of COVID will be on this. The Trust Mortality Task and Finish Group continue to oversee the Trust-wide programme of work. Page 6 gives an outline of the upcoming Safeguarding PLTC event entitled The Lifelong Legacy. This will take place on the 13th of May as a virtual event via Zoom. A safeguarding adult review about David has also been published, including David's life, the circumstances of his death, and this was published, his death happened in 2020, and it was published including lessons for all agencies around working together to ensure opportunities are not missed across a system and where care interacts across different agencies. There is a full link, a link to the full report within the document if you wish to read it all. Page 8 has links to the CQC reports of inspections of care homes and community providers published in March this year. And moving on through onto page 9, the safeguarding focuses on the ICON initiative and a link to the 3-step approach, ICON being the infant crying is normal, comforting methods may help, it's okay to walk away and never shake a baby. So it's an initiative to prevent injury to very young children from shaking. And acknowledging some of the stresses and how to cope with those in families with very young children. The safeguarding section also includes an overview of some of the work undertaken within the multi-agency safeguarding hub, with figures there on the work which we usually include. And moving on there to the CHC work, the team continue to work closely with TRFT and RMBC to achieve all elements of the CHC COVID backlog and the back to normal working. There are links to the relevant guidance for those who want more detail to see what we're working towards and the guidance that is guiding us at this time. As you can see on table 1, the team are well on trajectory to complete all assessments for those discharged from hospital between March and September last year under the rapid discharge arrangements to free up bed space during the early parts of the COVID pandemic. TRFT continue to submit regular updates to the CQC on progress against actions resulting from the last inspection reports. A warning notice from the CQC notifying the trust that the CQC had formed the view that quality of care required significant improvement was first received by the trust in November last year, and following discussion with the trust was finalised and issued on the 11th of February this year, and a number of actions have been identified and an action plan submitted by the trust to the CQC by the required date. As part of this total overview work and working together with NHS England and Improvement, a quality risk profile was completed by the CCG with input from the trust and NHS England and Improvement. It's a joint tool identifying all areas of risk and evidence how across the whole trust and how those areas are being addressed. A joint meeting has been held to review the scores and the CCG is working closely with the trust and NHS England and Improvement to ensure oversight and appropriate assurance is evidenced regarding progress against any actions identified and any areas of risk where the scoring was high. CQC were party to that meeting and didn't express any additional concerns beyond the warning notice. This is additional assurance that we're seeking across the system and will also feed into the contract quality work that the CCG undertakes and the quality surveillance group, which is chaired by NHS England and Improvement. Towards the end of the report on page 18, you'll see an overview of the emerging findings and recommendations contained within the independent review of maternity services at the Shrewsbury and Telford Hospitals NHS Trust that are documented in the Ockenden report, providing maternity services were required to implement 7 immediate and essential actions and provide assurance of this to NHS England and Improvement. We were also copied into this assurance as the lead commissioner for the trust, and TRFT submitted their assurance assessment tool and will be monitored both locally by the CCG via contract quality group meetings and regionally by the local maternity system. TRFT are seeing, as you'll see in the report, continued improvement in VTE assessment compliance, with the medical director continuing to drive delivery of this. And happy to take any questions.
Thank you, Sue. Any questions for Sue? Chris?
Thanks, Sue. And just to thanks, Sue, for raising the maternity profile at governing body as well, because I think over the next 12 months, maternity is going to be absolutely top of the political agenda because of the Ockenden report into Shrewsbury and Telford. But I think there's a further inquiry as well that's expected to report in the autumn. So it's really important as a governing body that we understand the impact of the maternity report by Donna Ockenden, but also the 7 actions at the trust. Our local trust has really responded well so far and is reporting compliance with the 7 actions. So but it'll be continuous. So just to make sure people are aware, and it might be worth getting a steer from governing body about how we give you that assurance relating to these maternity inquiries and the local position.
Yeah, and I can continue to include updates as appropriate that come through from contract quality. And just to note, those 7 overarching actions are underpinned by quite a few essential actions that lead into objectives that lead into each one of the actions. And we also mustn't forget the work of the Maternity Voices Partnership and how that complements and works into the local maternity system.
So, Chair, in Parliament they agreed the terms of reference on an inquiry into the East Kent Trust, and that's expected to report in the autumn. So that's why this will continue to be high on the radar. But yeah, and we have got we have to call it an LMNS nowadays, don't we, Sue? I can't cope with 4-letter acronyms, but it's the Local Maternity and Neonatal System. So we're in the South Yorkshire and Basset Law system, where then the idea is...
Sorry, I forgot the end.
Yeah. It's a new change, isn't it? So the idea is we work together to support each other to make sure as a maternity system we deliver the best possible services.
Okay. It's really, the thing I find interesting now is that as we're getting the figures back for infection control for last year, is that whereas in primary care as we moved to remote working was how we would use antibiotics appropriately, and it does seem that we are, having changed our working practice, there is no spike or change in infection rates, which I think is reassuring that GPs have continued to prescribe appropriately even in a changed environment, which is a good thing.
I think that's a good point, Richard. It also leading into that, medicines management work very closely across the CCG with all practices, and they have quite a strong focus on antibiotic prescribing.
Yeah. Okay, any further questions for Sue on that paper? Okay, shall we move on then to public engagement?
Yep, enclosure 12, I'll give a brief update and ask Debbie to join in towards the end. So COVID vaccination remains at the top of all community conversations, as you can imagine. And there are also COVID-related inquiries coming in via Health Watch. An online PPG meeting was held on the 9th of March, which again included a conversation about COVID and the vaccination programme. And the next meeting will be arranged for some time during June. Lots of positive feedback has been received from those attending and supporting COVID vaccination clinics as volunteers. And as of the 31st of March, there are over 270 volunteers supporting the vaccination rollout in both clinics and booking roles. Over 2,000 volunteer sessions have been filled, making up over 9,000 volunteer hours. And Helen has great fun working all this out for me when I ask her for some stats. We've drafted, when I say we, Debbie has drafted a letter of thanks which will go to each volunteer, and she's allowing me to put my name to it as well with herself. And we do both think it's important to give some personal feedback to every volunteer, and that's in process of being pulled together to be sent out. The Engagement and Communications Committee met during March and received updates that included volunteer support to vaccination clinics, the vaccination rollout, including communications messages which change frequently and need to be updated, and plans to support mental health, the user voice being heard, and challenges to this that lockdown has posed. The engagement section of the CCG annual report, it was also discussed. This is completed and recognising a need to make an effort to reflect how different the last year has been. Helen's maintaining contact with a variety of community groups and offering support where appropriate. These include across the patch, Rotherham Carers Forum, Crossroads, Rotherham Older People's Forum, Health Watch, Age UK, the Ardash Listen to Learn and Carer Champion sessions, and apologies to any that I've forgotten, but there are many more. And I'm happy to take questions but firstly, perhaps ask Debbie if you've got anything to add to that.
No, I think you've summed up. It's been a busy few weeks and months really since we had the PPG network meetings. We had 10 GP practices were represented at the one we had about 3 weeks ago now, which is great to see. And like Sue says, lots of positive voices, and we definitely want to mark, like Sue's described, our thanks to each and every volunteer that has come along and helped out with that vaccination programme. So that's why we're trying to send the letters of thanks really. Working very closely with all our partners, people like VAR and Ardash and Health Watch, and I think it is this idea now of giving people support with regards to their anxieties and mental health, and going forward, just how we're well placed in Rotherham, but how we can continue to build on that and support the patients and public that have found it very difficult, and will find it difficult as we go into whatever is the next phase of this pandemic really. So yeah, thanks Sue, I think again a good summary.
Okay, any questions for Sue or Debbie? Okay, and I think the board is fully supportive of you sending out that letter on our behalf, Debbie and Sue. It's an amazing contribution, especially we still need them going into a booster vaccination season in the autumn.
Yeah, and I think it's important, Richard, that we also recognise that we're trying to capture that the essence of volunteering just going forward, you know, beyond the pandemic, which there will be at some point. You know, the people that have perhaps tried it for the first time will actually want to commit to volunteering and how much they get out of it, in whatever shape that volunteering might take for them in the future.
Okay, thanks. All right, I don't see any other hands up. Should we move on then? An on-call test, Ian.
Thanks, Chair. I think Ruth was just going to cover this one off.
Okay. Well, there.
Yep.
It's default putting your initials against anything, Ian. You know that by now.
Thank you, Chair. If I can speak to this one, that'd be good.
That's fine.
So this is something that we have to do every 6 months. We have to do one of these communications exercises. So it's totally unannounced. Nobody knows that we're doing it. I just pick a date in the diary and ring TRFT switchboard and ask for the on-call officer. I was lucky, it was one of ours. I spoke to the lovely Wendy as the on-call officer, and the test was completed in 6 minutes without any kind of issues. So if governing body could take some assurance from that test, we'll be doing another one in 6 months' time.
I think we can. Wendy's not frowning that she had any trouble with it, so that should be fine. Okay, thank you. Right. Okay. We'll move on to medicines management then, which has Stuart Lakin's name against it, but also Wendy's. So this is the usual test for Wendy to see whether she's been...
It does, Chair, but I'm desperately hoping that Stuart is attending, as we absolutely need him to present this one. I can't cope with the clinical questions. I mean, I'll be entirely disappointing. And it is just for information.
I shall let you desperately text Stuart. I will go through the minutes from the other meetings while we're waiting for him. Okay, so just moving on then, we have primary care committee meeting. Janet?
Sorry, Chair, you caught me a bit unprepared there. These are the minutes from February. So they're here for information. I'm happy to take any questions. I mean, with the pace of how things develop, things have moved on since then in numerous areas. I think I just want to highlight to governing body, because we were highlighting good news stories earlier on, just a couple of good news things from here is that one, we took the, as well as the other areas that we discussed, we took the primary care team work programme, which is a quarterly update, and it was a really good update, and sort of and most actions are on track, and those that are off track because of external reasons, not to do with the team or the primary care team. So it's just to note that it's a really positive position, and it's good for the primary care as a whole and the primary care work team. And the other thing was just a verbal update that we took on telephony, which was some funding that would enable practices to update their telephony systems, which was really good news too. Other than that, I'm happy to take any questions.
Okay, questions about that? Okay, no questions, Janet. Any delivery board, Ian?
Nothing specific, Chair. There's a couple of sets of minutes from January and February, and you'll probably, as members of the governing body, you'll just see the tone of the dialogue in terms of managing through the COVID pandemic and the activity coming through the system at that point. So nothing specific to flag, but I'm happy to take any comments or questions on that, Chair.
Okay. Comments, questions? No. The good news, Wendy, is that Stuart is joining us.
Yay!
So we'll move back to Men's Management Report. Stuart, welcome.
Hello, sorry, I'm just clicking on the screen. Right, can you? Yes. Right, okay. Right, got video off mute. Right, Richard.
Yep, fine, Stuart. Unfortunately, Stuart, we're just straight into you to present about Medicines Management Quarter 3 report.
Okay, hi guys. Okay, so challenging year for us, as like for everybody, but it's beginning to get some sense of it at the moment. Up to quarter 3, the important thing for finance is that our cost growth is below the average for England and the Yorkshire area, and again we benchmark very good with sort of CCGs that were matched to demographically regarding both cost growth and item growth. It's been quite challenging in the initial part of the year, and the one graph which I'll go to, it's be good if I could share my screen, but looking at the NCSOs, which is the drugs which are not obtainable at drug tariff price, that's added £899,000 to our costs this year, which is 70% of our total cost growth of 1.281k. So
Stuart, you should be able to share your screen if you want to show anything.
Okay, thank you.
May not have wanted me to have told you that, but
let's see if I can. Okay, yeah. So if you can see the screen now, that is the graph I'm talking about. So this is the NCSO issues that we had at the beginning of the year. Very difficult to predict. We can't move patients from these drugs because the majority of it was an antidepressant, which is the first line antidepressant according to NICE. You can't just switch patients to an alternative. And I say that contributed to 900k to our total cost growth of 1.3k, which is around 70%. But either way, as it is at the moment, cost growth is looking relatively competitive to CCGs that were matched to, such as Barnsley, Wakefield and Doncaster. And as I said, we are below Yorkshire and England average. So even finance must be happy with that. And that's largely due to reduction in item growth, which again is quite competitive as well. We had some issues at the beginning of the year, phase 1 of lockdown, where it would appear that much of the work that we had done around the self-care agenda had unravelled. That now appears to be back on track, and that again is looking at our lower than average item growth. Okay, so from the sort of the CCG wide cost and item growth is looking okay. We've got quite, Richard, you're excused because Richard's practice has actually merged with another practices, which is why it's showing his cost growth and item growth to be leading the pack. That is due to a merger. But we have got quite a big variation in the cost growth and item growth between the various practices, which the team are now actually delving into with intermediate practice to actually have a look at why we are where we are. One of the interesting things that's happened during lockdown is we were expecting, because GPs could not see so many patients face-to-face, antibiotic prescribing to increase. As a CCG, we've always been at the wrong end of the antibiotic prescribing national graphs, and we've never managed to hit the national target regarding volume. This year we have had, because we've seen a 16% decrease in antibiotic prescriptions issued, which again is one of the biggest decreases in the area. We've hit the target for this first time this year, and the volume of antibiotics prescribed, but so has everybody. And again, the reduction in antibiotic prescribing items is quite remarkable across the different practices. So we're trying to dig down into the practices on that. We've sent out the bulletin this month, the prescribing bite size, which kind of picks up on this. And we want to we're working with practices to make sure that we don't just revert back to, this is a time for us to reflect and learn from antibiotic prescribing, and so that we don't just revert back to the high prevalence of antibiotic prescribing we had in the past, and we try and capture that learning going forward and keep some of that reduction into subsequent years. So that's the global graphs, sorry. QUIP, it's been difficult to deliver QUIP. We had a very ambitious QUIP program at the beginning of the year, which we're hoping to get back on track going forward into the next financial year. We have managed to launch the revised infant feeding pathway, and that's working relatively well. We've had 92 referrals, all except the one that DNA had been received within 7 days of the GP referring to them. Only 6 of those have been forwarded on to a paediatrician. Before we put this pathway into place, when we mapped out the referrals from GPs, about 50% were going to a dietitian, 50% were going to a paediatrician. The waiting time to see the paediatrician was much longer than the dietitian. So, and only 3 of those have gone on to actually be tested for allergy. That's working relatively well, despite a launch in difficult times. The antidepressant medication reviews, really excited by this project, which is about to go live. This really takes on from engagement work we did over 2 years ago, looking at antidepressant prescribing. We're about to launch those reviews. We've talked to all the PCN groups. We have a impressively strong uptake from practices who, when we first talked to them about reviewing patients on long-term antidepressants who didn't need them, were a bit skeptical. Now they all want to work with us, so that is really encouraging, and we're about to start those reviews imminently. Okay, and again, we're working on the insulin work as well. We've taken that forward. Prescribing incentive scheme, we only launched that halfway through the financial year because of difficulties with the COVID lockdown. We totally revised the scheme to what's operated previously. At the moment, it's actually better than this now because we've rerun the data, but at the time of writing the report, of these 377 potential performance indicators, 270 have been achieved across practices, which is 72%. And that actually compares very favourable with previous years. We've also got the care home team working away. They didn't get their data to me in time for the report. They have been soundly beaten, but on average, the care home team are working with 540 patients a month that we're ordering the medication for, and they're doing on average 288 clinical interventions a month on care home patients. We're also set to hit these 2 targets for proxy ordering, which is basically getting the care home to order medication electronically rather than paper-based. The NHS England have given us 2 targets, 25% and 45%, and we're on schedule to hit the 45%, the highest target, which is the only CCG and the ICS to do that. It's been very difficult because we're not getting to care homes to actually look at the waste, but we have done some waste around insulin prescribing in 2 care homes, where we identified £625 of waste in one and £498 in another, and we did a waste order in a further care home which identified £761 of waste, which we prevented. We're not been able to track waste over the whole year because of the circumstances that we're kind of working in. So I'll stop sharing. That's kind of a brief summary of where we are and what we've achieved. Any questions?
Okay, Sue, followed by Jason.
Just a couple of quick statements, really. there is a link. You weren't here earlier, Stuart, when we were talking about infection prevention and control, but there is a strong link between medicines management and Emma, the CCG infection prevention and control nurse, in terms of C. diff, E. coli and antibiotic prescribing. So that does work together. I'm just fielding off a question that I thought might come my way. And just to mention as well, Debbie might mention it or add to it, at the start of the antidepressant work, Stuart did come to the patient participation group network and did a bit of a dispelling the myths and a question and answer, and which was really well received, and everybody took part in that and was really up for supporting the progression of that work.
So can I just take the opportunity to come back to you as well? We've also, next week, we've got the first meeting of the hydration group, which is now linked into an overarching care homes group, which is was part of one of our quick schemes, which is looking at encouraging better hydration of patients in care homes. This is a multidisciplinary group working with dietitians, continence and wound care and our care homes team. And we've got 3 care homes already signed up to take part in that scheme. And that will also link into one of the outcomes, although I've got no idea how I'm going to measure it yet, is a reduction in UTIs, but it's taking on work that was done in East Berkshire where they managed to do that. So again, that links into the anti-prescribing element as well.
I think that's an excellent piece of work, because we know care homes often need support around hydration and nutrition.
From the initial audit that the dietitians did, we estimate we can prevent 650 bed days a year, because that's how many bed days are taken up by patients from care homes who go in where dehydration is the underlying cause.
And that improves patient experience. Sorry, it's a bit of a dialogue between me and Stuart.
Sorry.
I'll shut up.
Okay, Jason.
Sure. I know from my practice data that some years we seem to go up in prescribing, some years we seem to go down. Have you ever looked at the practices over a longer term, say a 5-year term, to see whether there's any actual or any practices are actually diverging away, or whether it's just yearly wiggle? It's my first question. Then my second one is more of a comment again about antibiotic prescribing. I seem to be prescribing more antibiotics personally when I see people, because you tend to take less risk when you're dealing with more people over the phone. But obviously, overall, fewer people are coming forward with those sort of infections. So it'll be interesting to see what happens when we start seeing more people face to face, whether it's really us that's changed, as in the doctors, or actually is it just because of lockdown? Have there just been fewer infections around? I think it's probably the latter mainly.
And that's really interesting, Jason. That's the conversations we've been having, is this reduction in antibiotic prescribing. Is it due to the fact that we're not mingling and mixing as much, so there are generally less infections? Or is it the fact that because, when you go and see your GP and you're sat there's an expectation that you come away with something, and that you've been shortchanged if you don't come away with a prescription, or if you just come away with a bit of advice. And it's about trying to that's the conversations we want to take forward over the next sort of 6 months to try and capture that. I think it's probably a mixture of two. I don't think this antidepressant prescribing rate will stay as low as it is, but it'd be good if we can actually sort of not bounce back to exactly where we were before this year. And secondly, we do loads of number crunching on prescribing and look at list sizes and that, and also your disease registers as well. That's how we set the budget. So yeah, we do go back more than 12 months. We're all pharmacists, Jason, but we're data geeks at heart.
Okay, Ryan.
Thanks, Stuart. I just wanted to ask you about, you mentioned some examples of wastage in care homes, particularly around insulin. So if there is any wastage which is identified, how does that kind of get saved or recorded? Because I'm assuming wastage, does it get, is any mechanism to pick up on that, or where's the savings?
This is one of our work streams going forward into the year. So with most insulin prescriptions, the dose is not actually recorded on the patient's prescription. So what we're trying to do is we're trying to work through. We've got nearly got 3,000 patients on insulin. It's trying to confirm the dose and then look at the quantity to make sure it matches the dose. Invariably, it doesn't, and particularly in combs. And this is where we get masses of excess. It's not the same amount goes in every month, and it's just not being used. So we've been working with two CCGs that not particularly match to us, Islington and Haringey down in London, where they've done some work on this. And they got a 20% reduction on insulin usage just by actually resolving the waste issue. So we're kind of replicating what they're doing. And we've got a member of the team, Sally, at the moment, who's working with two of our practices which perform least well on managing blood glucose, looking at confirming the doses of insulin that patients are taking. Does their prescription match what the doses is? But also then identifying patients who are using high doses of insulin, over 100 units a day. We're trying to get them then into sort of refer to the dietitians for weight loss and dietary advice. And again, we've got some preliminary work which shows that if we can actually encourage the weight loss, we see less insulin being used, which is again better for the patients. That's one of our work streams, which has got kind of stalled a bit over the year, but we're just picking up again now.
Well, good luck with that one.
Yeah, it's going to be a challenge, but that's what we're about.
I think my second point, if I may, Richard, is to do with what Jason said about antibiotic prescribing and the numbers of the tendency perhaps to prescribe antibiotics for patients, because I think when you're doing non-face-to-face consultations, there is a slight anxiety about not actually seeing the patient, and you want to do best for the patient. And obviously, I think the natural response sometimes is to do something and give the patient something. And I think it's quite interesting to see that actually antibiotic prescribing is going down rather than the other way around. I guess it's a phenomenon. We don't know. Perhaps it's related to your suggestion that people are not mixing around and maybe not exposing them to risks of picking up infections. Or maybe when the dust does settle, we will kind of review our own practices, and we might find that we were perhaps using far too many antibiotics anyway to start with. It's just a comment.
Thanks, Ryan. Any other comments for Stuart? Okay, well, thank you, Stuart, for coming on quickly at Wendy's insistence. She was having a massive panic at the thought of having to present the paper herself. We will get her to do it at some stage. Thanks. You and your team keep up the hard work.
Okay.
Thanks.
See you all. Bye.
Okay, moving back to the agenda and then minutes from other meetings. John, Aqua.
Yes, Chairman, just two things I just wanted to feed back to the governing body. Firstly, the audit committee have approved an internal audit plan for 21-22, the new financial year. It's quite a flexible audit plan, really, reflecting just the environment we're working in at the moment around COVID and organisational change, but we have put that plan in place. The second thing just to note is just around the head of internal audit opinion, and the audit committee have seen the draft head of internal audit opinion now. The governing body will see that when it's formally issued in June. But the level of assurance that we're getting in terms of our work on the GBAF has reduced a level, and that really probably reflects just the environment we've been working in terms of command and control and COVID. And we know what we need to do to really get that level of assurance back up in the new financial year. But just to report that to governing body, and we'll see the final report in due course.
Okay, thank you, John. Any questions on that from anybody? No? Okay. Chris, the ICS.
So these are the minutes from February Health Executive Group. So the key headlines at the meeting were around planning both at place and at ICS level. The vaccination programme, and obviously we're managing it at Rotherham footprint, but we're also managing it on a South Yorkshire footprint. And the ICS, the future ICS design group is starting to take shape now. So there's 3 products being worked on. One is a compact, which is a values and behaviours document agreement, which we seek to work to. So that'll be produced over the next few weeks. A development matrix for our places, so we can be assured by 1st of April 2022 our places are in a strong position to take on as much delegation as possible. And the 3rd product is a roadmap to April 2022, so we can understand what our key pinch points, development points, decision points will be. So I'd expect to be sharing over the next few meetings a compact, a development matrix, and a roadmap.
Okay, thank you, Chris. Jeff, then, Members Committee.
Thank you. Yeah, from February, again, a bit like Chris saying, just an overview, sort of the COVID updates, white paper, mental health, we had a discussion about, and the changes there in terms of sort of transition, in terms of ICS, in terms of our members committee, obviously with the CCG sort of disappears in terms of sort of that, how we organise that transition, and the voice of primary care being into the future. So then, is there anyone any questions specifically?
Any questions, comments for Jeff? No, that's fine, Jeff.
Thank you.
Okay. Then moving through the agenda, don't think anyone raised any future agenda items. Oh. I shall welcome Ben. Just as we're finishing off.
Bad timing.
That's fine.
Apologies.
Any other urgent business? No one's notified me of anything. I don't think there's anything we need to escalate. Any risks raised? Okay, in which case we shall take the following resolution that representatives of the press and other members of the public be excluded from the remainder of this meeting due to the confidential nature of the business to be transacted, publicity on which would be prejudicial to the public interest. And we'll call the meeting to end. The confidential element will start at 2:15. And I say welcome and thanks for coming.